medcram.com.
Welcome to another MedCram update. We're going to talk today about absolute risk reduction and relative risk reduction. Which is the right one to use and which one's better? Boy, I have seen a lot of usage around social media and a lot of people talking about absolute risk reduction. And it kind of goes along with this blog that was written on PLOS. This is called Absolute Maybe. It was written by Hilda Bastian back in June of this year, titled Another Bit About Pandemic Fallout, the Weaponization of Absolute Risk Statistics. And there's a lot of people that are talking about relative risk reduction, absolute risk reduction, number needed to treat. And most of them, I'm noticing, don't really know what they're talking about. And today we're going to talk about these issues, how they relate specifically to COVID-19 and vaccines. And I'll tell you that when you get done with this video, you're going to know more than 90% of physicians that really don't have a clue. I'm saying that quite honestly. The issues with relative risk reduction, absolute risk reduction. In fact, there was an interview, which I'll link to, with Peter Attia and Paul Offit, where they kind of dance around a little bit the issue of absolute risk reduction and relative risk reduction in terms of the vaccines. So what is it that we're going to talk about? Relative risk reduction, absolute risk reduction. It's not going to be dry. It's actually going to be an interesting topic that we talk about. But who are we? So we are MedCram, medcram.com, where we explain medicine clearly. I am a pulmonary and critical care sleep specialist. I am a professor at 2 Southern California medical schools, co-founder of medcram.com, where we publish continuing medical education topics on our website, and they have been used by thousands and thousands of healthcare providers around the world, also used by publishers as well. So whenever you talk about something here about COVID-19 on the internet, people are always trying to figure out your angle and what your biases are. So I'll just say right up front, we are not political whatsoever. This chart here describes this really well. You've got the political left and the political right and their leanings, some of which I think are good and some of which I think are bad. And so when I start to assign something, for instance, when I start to criticize that people are assigning bad motives to authority, which we're going to talk about today in terms of pharmaceutical companies and the risk reduction, I don't want you to think that I sign up for everything on this side either. As you can see here, we at medcram.com believe that the vaccines actually do work, that there are things that we can do in terms of responsible behavior, listening to authority, that people who kind of know about these things, yeah, they make mistakes, but generally speaking, it's a good idea to listen to authority. We do our part for society and we use modern technology, but that doesn't mean that we don't look for immune-enhancing interventions like we've talked about. We've talked about sleep, sunshine, diet, lifestyle, and we talk more about those things on our website. We also talk about responsible liberty, making sure that you're doing your part. I think that natural immunity is a thing and it should be taken seriously. And of course, we obviously believe in early treatment because we were the ones that were spearheading that campaign very early in February and March of 2020. So let's get started and let's talk about what I think are the problems. And usually it starts out this way. Let's take a look at the example of, for instance, statins in diabetics over a 4-year period of time, taking it every single day. You'll see this kind of statistic. So if you take 1,000 people in the placebo group, as you can see here, and 1,000 people in the statin group. And what you find at the end of 4 years is that 28 people out of that 1,000 had a stroke. If you put them on a statin every single day, only 15 of them will have a stroke. How does this work? You can calculate something called the relative risk reduction. The relative risk reduction is simply how much did this go down by as a proportion to how much it was in the first place. So that's simply 28 minus 15 divided by 28. So that's 46%. So in other words, you could reduce strokes in diabetics by 46% if you gave them a statin every day for 4 years. That's called the relative risk reduction. And that's a number. Imagine 46% reduction. That's something that you'd probably want to sign up for. But the problem with that statistic is it doesn't take into consideration what the prevalence is of this disease in the population. Obviously, 28 in 1,000's got to count for something. And so there's something called the absolute risk reduction. And what's the absolute risk reduction? It's that same difference, so 28 minus 15, which is 13, divided by not how many people get the disease in the end, but how many you treated in the first place. 1,000 people. So that's a 1.3% reduction. So you can see here, 46% versus 1.3%. Obviously, the absolute risk reduction is always going to be smaller than the relative risk reduction. So another thing that you can do is you can take the reciprocal of this 1.3% and you will get the number needed to treat. In other words, how many people do you need to treat to prevent one person from getting the problem that you're talking about? So in this case, the number needed to treat is equal to 1 divided by the absolute risk reduction. So 1 divided by 0.013 is equal to 77. 77 people you treat to save 1. And the point is a good one if you think about it, right? So you're coming to a patient in your office who has type 2 diabetes and you tell them, look, over the next 4 years, if I give you this statin drug once a day, every day you take it religiously, we can reduce your incidence of stroke by 46%. Now, it may have been very rare to begin with. So how does that get taken into consideration? Another way of saying it is that if I treat you with this medication, there's a 1 in 77 chance that you'll get a stroke. So that's the number needed to treat there, 1 over the absolute risk. Why are we able to make this determination here? We can report the relative risk, we can report the absolute risk reduction, but obviously it looks better to say 46%. And this is where a lot of people have said that the pharmaceutical companies are putting a fast one over us by using relative risk reduction. And I'm not going to argue with that. Obviously, they have to do their marketing, but I'm not in the business of attributing motives. I'm just looking at raw data. That's all we look at here. 46% relative risk reduction in this case, absolute risk reduction is 1.3%. Here we have a graph of the incidence and the relative risk of stroke in the diabetic and non-diabetic population between 1998 and 2014. Here is the people with diabetes, and down here are the people without diabetes. But generally speaking, what do you notice? It's flat. The prevalence of stroke in type 2 diabetes is not changing. It's not changing. And so therefore, you could report either one of these things, and it wouldn't matter, just so long as you understood which one you were reporting. The point here, though, is that absolute risk reduction, as you can see, has a lot to do with the prevalence of the disease. Let's look at this again here. Relative risk reduction is this difference right here divided by this difference here. Whereas absolute risk reduction is this difference right here divided by this distance here. And so you can see very clearly that we could still have a 46% risk reduction if we did something like this. So the relative risk reduction would still be 46% risk reduction, but the absolute risk reduction would be very, very different. So here's the point that you have to understand. The absolute risk reduction is very heavily dependent on the prevalence of the disease when you test it. Okay, so we're going to go to skydiving just to illustrate how much the absolute risk reduction is influenced by the specific environment that the test is conducted in. So for this experiment here, we're going to assume that a parachute is 100% effective. I know that there are cases certainly where people have jumped out of airplanes with parachutes and did not survive. And there's even been some that have jumped out of airplanes without parachutes that have survived. But for this illustration, we're going to assume that if you jump out of a plane at 20, 30,000 feet, you're not going to make it. And that if you have a parachute, you are. So imagine we have two planes. We have planes where everybody on board has a parachute, and we have planes where nobody has a parachute. And we select out of 300 people on that plane, 2 random people that are going to have to jump out of the plane. Now, of course, this is obviously not an ethical experiment, but I'm using this to describe what's going on. We've got 2 planes. We have a plane without anybody wearing parachutes and a plane where everybody is wearing a parachute. And we're going to select 2 random people on these 2 planes to jump out. Obviously, where nobody's wearing a parachute, if 2 people are going to jump out, you're going to have 2 deaths. So in this case, jumping out of the plane is the disease, and dying is dying, and the parachute is the vaccine. So in this case, we're going to have 2 deaths in the no parachute group, and we're going to have 0 deaths in the parachute plane, because 2 people are going to jump out, they're going to have parachutes, and they're going to land. Now, let's do our calculations. So the relative risk reduction is going to simply be the number of people who died in the no parachute minus the number of people who died in the parachute divided by the number of people who died in the no parachute. And that's going to be 100%. So we just saw here that the parachute is 100% effective at reducing death in the disease of jumping out of a plane. What about the absolute risk reduction? So here, the numerator is the same. Again, 2 people died in the no parachute minus the number of people who died in the parachute. But now we're dividing it by the number of people who actually were at risk So this is the number of people who actually got the vaccine in this case, or the parachute. And you can see here that even though the parachute is very, very good at preventing death, it's 100% good at preventing death, the absolute risk reduction is only 0.67%. Why is that? It's because such a small amount of people on the plane were subjected to the disease. And that's why the relative risk reduction is dependent only on the efficacy of the intervention, whereas the absolute risk reduction is dependent both on the efficacy of the intervention and also the prevalence of the disease in the population. There were only 2 people that were randomly selected in this situation to jump out of the plane. And that's the reason why the absolute risk reduction is so low. Now let's do the number needed to treat. And that's simply the reciprocal of the absolute risk reduction. And in this case, it's 1 over 0.67%. And that gives you a number needed to treat of 150, which makes sense, right? Because if you have 300 people and it's randomly selected, if you were to treat 150 people at random, the chances are that 1 of 2 of the people who were to jump out of the plane would not have died, because at least one of them would be wearing a parachute on average, and that person would be saved. And so this number needed to treat rings true. Let's change the experiment a little bit. So in this situation, everybody jumps out of both planes. So this is going to be a disaster for those that are not wearing a parachute, because what happens here is that all 300 people jump out of the plane and all 300 people die as a result of not having a parachute. But in the parachute plane, where everybody was vaccinated, again, because the intervention is 100% effective at preventing death, nobody dies. So let's do our calculations now. It's still 100% effective. We know that because the vaccine, or in this case, the parachute, hasn't changed. People are still deploying it. They're pulling the ripcord. They're jumping out. The parachute is working exactly the same. So it still has the same effectiveness. What has changed in this case is that the disease prevalence of jumping out of a plane has gotten much, much more common. So what happens now with our absolute risk reduction is, instead of 2 minus 0 divided by 300, we now have 300 minus 0 divided by 300, and the absolute risk reduction is 100%. You'll never see an absolute risk reduction like that. It's impossible to get that high. But in this hypothetical case, we've done it because we made everybody jump out of the plane. So what's the number needed to treat? Obviously here, if everybody is going out of the plane, then all you need to do is give 1 person a parachute and you are going to save a life. And that's exactly what we see here. We see the reciprocal of 100%, or 1 divided by 100%, is equal to 1. So all you have to do is give 1 parachute to just 1 person on that plane and you will save 1 life. So you can have an intervention that is 100% effective at preventing the thing that you want it to prevent, and you're still going to get absolute risk reductions that can be anywhere from very, very small at less than 1% to 100%. So what does that tell you? Absolute risk reduction tells you about not only the intervention, but also the environment that that intervention is deployed in. And that's great. I mean, if you're dealing with a situation or a disease where the prevalence of that disease is not changing, for instance, coronary artery disease, stroke and diabetes, COPD exacerbations, that's great. That'll tell you exactly what the intervention's efficacy is and impact is going to be in that population. If you switch that to a different population, that absolute risk reduction is no longer valid. It's going to change because the prevalence of the disease changes, the risk factors change. The other thing is this number needed to treat can be very effective, but also remember that the number needed to treat is the reciprocal of the absolute risk reduction. So the bottom line here is that both relative risk reduction and absolute risk reduction are very important factors. They tell you different things. It's not that one is better than the other. It just depends on what you're looking for and the information that you want. These are great tools that will provide the information that you need in a specific situation. If you want to know specifically about the efficacy of an intervention that transcends the environment, then your best bet is going to be the relative risk reduction. If, on the other hand, you want to know, for instance, the efficacy of a deployment in a particular situation at a particular time and place, the absolute risk reduction can be very, very helpful. Where things will get a little bit interesting as we move on is with vaccines, because vaccines are not taken to give protection at the time that they're given. They're given in populations to protect them at some point down the road. The problem is that down the road may change. In other words, there may be a surge, there may be an increased risk, and that's what we're seeing in these types of situations. So if you get a measles vaccine, it's not because the measles that's going around at that moment, but the potential possibility that you could be exposed to measles at some point in your future life. And so that's why when you look at the situation at the time that the tests are done, the absolute risk reduction, which is a factor that employs not only the efficacy of the intervention, but also the specifics of the environment at that time, that may not be applicable. And so that's something that you need to keep in mind. If you take a look here, here is treatment A, we'll call that placebo, and treatment B, which is the intervention. Notice that there's about a 25% reduction here, there's about a 25% reduction here, and there's about a 25% reduction here. So the relative risk reduction is 25%. However, what we're looking at here is the absolute risk reduction now, and the absolute risk reduction is all about what's the distance between this relative to the distance of the whole thing. And you can see here clearly that when the risk goes up, so this is a high-risk situation, this is where the prevalence of the disease is very high, the absolute risk reduction, or the absolute distance between those 2 points, is the highest here than it is over here. So the lower the risk or the lower the prevalence, the lower the absolute risk reduction. The higher the prevalence or the higher the risk, the higher the absolute risk reduction. This is University of Western Australia. They know it, but I'll tell you, most physicians, most healthcare providers, most people who are on social media talking about how absolute risk reduction is far superior to relative risk reduction when you're trying to find out about interventions. Here's the key. The absolute risk reduction is dependent upon the baseline risk of the study, population, or individual patient. And that's the key that we're talking about. It's like this. Imagine you have a 20% off coupon and you take it into a store and you decide to use that coupon to buy a $1 pack of gum. How powerful is this 20% off coupon? The relative risk reduction or the relative reduction of cost by using this coupon is right there. It's printed on the coupon. It's the reason why we print it on the coupon, because it tells you the most information. It tells you that there is 20% off. How much does this absolutely turn into? Well, here it turns into 20 cents. But if you use the same coupon on a high dollar item, over here it's worth 20 cents. Here it's worth $200. So the absolute risk reduction here is 20 cents. The absolute risk reduction on the diamond ring is $200. But the relative risk reduction has stayed the same. That's the issue. It's like saying that a 20% off coupon, because it only gave you 20 cents off on the dollar, should only give you 20 cents off on the diamond. No. Absolute risk reduction changes with the cost of the item or with the prevalence of the disease. So let's get down to nitty-gritty. Let's actually look at some data. Here is a graph of 6 different countries that were used in the Pfizer-BioNTech phase 3 trials. Germany, the United States, where most of this was actually done, Turkey, Brazil, Argentina, and South Africa. They picked countries in the North Hemisphere and in the South Hemisphere just to make sure they had good coverage. The phase 3 trials took place here between these 2 dates, late July and sometime in November. I want you to notice here that the green line is the United States, and that's where most of the data was coming from. But you can see here the average prevalence of the disease runs right about here. That's the average prevalence of the disease. What's the average prevalence of the disease here? It's approximately 10 times that amount. What about during Delta? Delta is at least twice the amount. So we already talked about the problem with absolute risk reduction. It's highly dependent on the prevalence of the disease in the population. So what do you think if we were to assign the absolute risk reduction from the data in the Pfizer-BioNTech vaccine during the time that they actually did the phase 3 trials? We would get an ARR, or absolute risk reduction, that is specific for this period of time. It's actually even worse than that, because this is a very small amount of time, and so the absolute risk reduction only has to do with this amount of time period that we're actually monitoring the patients, whereas the vaccines could actually be beneficial over a much longer period of time. And that's a problem with absolute risk reduction. Remember what we said, it has to do with the risk, and it has to do with the prevalence of the disease. Okay, so let's take a look now at the J&J. So J&J was done a little bit later, as you may recall. And again, we're looking at the green. The average prevalence there was somewhere up here. So the prevalence of the disease was almost twice that in the J&J phase 3 trials than it was in the Pfizer. And that's going to become important later on. In fact, in the interview between Peter Attia and Paul Offit, they're actually discussing this. Peter Attia actually asked the question. He's like, how is it possible that the J&J vaccine had a lower efficacy? It was like 67% versus Pfizer's 95%. And yet, he calls it the true absolute risk reduction, or the true risk reduction, was higher for J&J than it was for Pfizer. Why is that the case? Well, you could answer that question for him, just based on this information and understanding what absolute risk reduction is and why this turns out to be the way it is. Let's look at that article here. Let's look at the Pfizer-BioNTech vaccine phase 3 trial. They say here between July and November. You can see what countries it's in. You can do this research yourself. You can look at Our World in Data and pull it up and do your own research. And they give you the numbers, 8 cases of COVID versus 162 in the placebo group. And they actually told you how many participants there were. So you can actually do calculations. It's not hard to do that. So once again, you know where the Pfizer group is for the phase 3 trial. You know where the Johnson & Johnson one is, and you can go to work. So let's take a look. So here's Pfizer. We've got the placebo group and the vaccinated group in the trial. And actually, these numbers are fairly similar, so I'm going to treat them the same in terms of calculations. Otherwise, the calculations get unnecessarily complicated. It's a little over 18,000. In the placebo group, we had 162 that came down with COVID. In the vaccinated, there was 8. So what does that mean in terms of relative risk reduction? Generally speaking, we're looking at 162 minus 8 divided by 162, and that equals about 95%. That's where the 95% efficacy comes from. And this is basically a relative risk reduction of 95%. And that has absolutely nothing to do with the prevalence, because this is the relative risk reduction. Relative risk reduction has nothing to do with the prevalence of the disease. Prevalence can go up, it's still 95%. Prevalence can go down, it's still 95%. Let's do absolute risk reduction. This is supposed to be the one that is the more robust. So let's take a look. We do again 162 minus 8, so we're looking for the difference here. But instead of taking it over the 162, we're actually looking at how many people got vaccinated. So we're dividing it by this whole amount, which is 18.2 thousand. Now for that, we get a very small number, 0.85%. This is less than 1%. A lot of people say, here is the true efficacy of the vaccine. Less than 1% efficacy. And this is the one that should be published, and this is the one that should be advertised for long after. Well, we'll come back to that. Let's look at the Johnson & Johnson vaccine. I can look at the same data in their New England Journal of Medicine article. You got the placebo, you got the vaccinated. Here you've got the 19,000 in one and the 19,000 in the other. Notice that there was 348 that came down with COVID in their placebo arm and 116 that came down in their vaccinated. Already, what do you notice? There's much higher prevalence rates. So because there's higher prevalence rates, you know automatically that the absolute risk reduction is going to increase by that same amount. But let's not jump ahead here. What's the relative risk reduction? Relative risk reduction is simply 348 minus 116 divided by 348, and that comes up with 67%. So this is why it gets published. 95% efficacy, 67% efficacy. Now let's go to absolute risk reduction. So again, we're looking at the difference, but instead of dividing it by the 348, we're going to divide it by the entire amount of people who got vaccinated, which was 19.6 thousand, which we have here, and we come up with, 1.18%. So we can ask, why is it that Johnson & Johnson had a higher absolute risk reduction than the Pfizer-BioNTech? How is that possible? The answer is really simple. It's just that it was done at a time where there was far more people that had come down with the disease. And that highlights exactly the point. And it's exactly the reason why you would never want to ascribe to a vaccine based on its phase 3 trials the absolute risk reduction, because the absolute risk reduction is specific to the period of time when the phase 3 trials are being done. If there is a surge, and that's the reason why people take vaccines, to avoid getting sick when there is a surge. This is the thing that people really don't understand very well. Again, here's when Pfizer did its phase 3 trials, relatively low prevalence at this time. And this is when J&J did it. Especially look at the green here, that's the United States. This is the point here, is that they had a higher prevalence rate of the disease, and therefore a higher prevalence rate is going to automatically give you a higher absolute risk reduction. Let's go back to the Pfizer data. So Pfizer, 162 going down to 8, 95% risk reduction, 0.85% absolute risk reduction. Let's say we gave the same vaccine, except it was when the prevalence rate of the virus in the population was 5 times or even 10 times. What would that do to the absolute risk reduction? Okay, so instead of 162 people coming down with COVID, we have 1,620 people coming down with COVID. And instead of 8 people coming down with COVID in the vaccinated group, we'd had 80. Exactly the same relative risk reduction, 95%, no difference. The vaccine is working exactly the same as it always does, just like the parachutes are working exactly the same as they always do. But notice what happens when we do absolute risk reduction. Instead of having 0.85% reduction, we have 8.46% risk reduction. So in terms of number needed to treat, if you actually do the calculation here, number needed to treat, which is simply 1 divided by the absolute risk reduction, you get a number of like 118. You've got to vaccinate 118 people here in this situation to prevent one infection, whereas over here, the number needed to treat, because the absolute risk reduction is so high, you only actually need to vaccinate 12 people. So really, really powerful. But notice, these numbers are different, not because of the efficacy of the vaccine. It's completely based on the prevalence. And this is the reason why absolute risk reduction is not a good measure of efficacy of intervention if it is an intervention in a disease that changes prevalence. So great if you want to use it for statins, because stroke and diabetics, that incidence doesn't change that much. Great if you want to use it in cardiovascular disease or lung disease or COPD exacerbations. No problems there. Knock yourselves out. But the real problem that we have when we're talking about a pandemic and waves and vaccination is that prevalence of the disease at one part of a couple of years versus prevalence of the disease at another part. I mean, we're talking about a 10-fold difference. That's extraordinary. So I went around looking at commercial advertisements. As a pulmonologist, I do see people with COPD exacerbations. And I found this interesting because here they advertise a 20% increase in exacerbation rate when you don't use Daliresp in these patients. And so here's an example of relative risk reduction. But I've also seen them using number needed to treat. Here's the number needed to treat. That, of course, is based on the absolute risk reduction. They say here that for every 5 patients treated over a year, adding Daliresp could prevent 1 additional moderate or severe exacerbation. That sounds like a small amount, but realize that these exacerbations of COPD, when they get into the hospital, they actually have a higher 30-day mortality than a heart attack. People are using absolute risk reduction in their advertisements. I think that's a good thing because the incidence of COPD exacerbations in that population isn't something that dramatically changes from year to year. Whereas, as you can see, this pandemic, that there is dramatic shifts in prevalence of the disease here. And so therefore, looking at the relative risk is a better way of looking at this, specifically because, again, we're not taking a vaccine for the risk of COVID at the time. It takes at least 7 to 14 days after the second shot to be fully immunized. So obviously, you're taking the vaccine to prevent disease down the line when there is a surge. You're going to have a completely different absolute risk reduction at that time than you would at the time of the phase 3 trial when, in this case, the prevalence was pretty low. On a side note, we are looking at this in early October of 2022, and I'm just noticing here that there has been a spike in cases in Germany. Obviously, we're going to have to keep an eye on that. As we've talked about in other episodes, there was a study that looked at the surges in Europe in the fall of 2020, and it was looking at the latitude. So we would expect to see a surge in cases in Europe since Europe has a higher latitude than we do here in the United States, and that's exactly what we're starting to see. We're also starting to see that a number of these other countries in the southern hemisphere are headed into summer, so hopefully that continues to trend down. We're also noticing here that the United States is continuing to trend down. Let's hope that continues. So I hope this has been informative for you. You understand the difference between relative risk reduction and absolute risk reduction. And of course, that absolute risk reduction is only good if you understand that the prevalence is represented at the time that you calculate the absolute risk reduction. And that if the prevalence of the disease changes, the absolute risk reduction is going to change with it. Please join us again for our next, and join us at medcram.com for further medical education videos and continuing medical education units. Thanks for joining us.